I lead a team of therapists who we call the monolingual service because they conduct therapy in English in 11 clinics around Rochdale, which is about 11 miles away from Manchester. And we also have a specialist bilingual team that only provide assessment and therapy in home language, in mother tongue. So it's that aspect I'm going to look at now. So if children have got speech, language or communication needs, they're given treatment in their home language and not in English. I'm just going to talk briefly about what the role of the speech and language therapist is with children with speech, language and communication needs, and also about language therapy, which even in the field of speech and language therapy and linguistics generally isn't very well studied. I think it's quite surprising that speech and language therapists have it in their title, and linguistics have an awful lot of research about how typically developing children acquire language, but there's very little on how majority of children who are bilingual acquire language, particularly communities that are sequentially bilingual, so acquire one language almost completely and then are exposed to English or Welsh or another European language after that. And yet that's how most children who are bilingual in the UK experience bilingualism. So my PhD was looking at code switching and language assessment in those communities. There's a large Pakistani heritage and a small but substantial Bangladeshi Sylheti speaking heritage population in the centre of Rochdale, and that's where I work. So our professional guidelines for communicating quality 3 state that speech and language therapists should not advise individuals and carers to abandon their mother tongue to facilitate progress in English. And we think that's really important, and why we have a service that provides input and assessment in children's home language. Only if the child has no real bilingual skills and has completely switched to English would we then transfer them to the English side of the service. And this is not just, as I was talking to some people, it's not just a PC thing. I'm not just being really on message. The research shows that when children have demonstrated that they can acquire a home language, that EAL will progress normally. So if children have problems in their home language, if we can sort those out first and give them a good foundation, then it gives them a good foundation for future language acquisition. SLT should strive to assess individuals in all the languages which they're exposed to. So in Rochdale, every time we have funding for a new assistant post, we always advertise it as a bilingual post. So we've built it up from 1 part-time therapist and 1 part-time assistant to now 3 specialist speech and language therapists with bilingualism in their job description, and as of next month 6 bilingual assistants who speak Sylheti or Urdu or Punjabi or Mithri. We also extensively use interpreters for Rochdale is a distribution centre for asylum seekers, so we have lots and lots of different languages. And although we're only a small post-industrial mill town on the edge of the Pennines, I can see the Pennines from my window, we have 35 languages on the caseload at any one time, and I'm sure that's gone up this year because that's those figures are about 18 months old. So we're a very busy bilingual team. So what is language impairment? I was having a discussion with my team. There are lots and lots of definitions and lots of different models. I think as we heard this morning, it can change the whole way that we conceptualise children's difficulties and how we respond to them. We increasingly know that there are 3 major things that need to be in place if a child is to successfully acquire any language, and that's inputs. They need to hear lots of language from adults and other children and their peers. They need to have pattern spotting abilities. So researchers like Tomasello have looked at how children use their general intelligence to spot patterns and differences, to make the rules of language in their heads, to spot what's happening. And that's a lot of that research comes out of the mistakes that normal children make and the errors and how children formulate their language over time. The final thing is that they need to have the social interaction skills and the drive to use their language. So that covers all the pragmatics. And for bilingual children, that can be quite tricky. I'm an advisor for the Royal College, and I get lots of phone calls from therapists saying, well, parents say he speaks another language, but when I'm talking to him, he doesn't. And I say, well, what do you expect? You're in an English-speaking school, you're white, he's not. You know, you started speaking to him in English, all the indicators are saying, speak English, so he's trying to do his best to fit in with you and be a good communicator. And it constantly surprises me that people overlook that. For that reason, when we do sessions, I discuss thoroughly with the co-worker or interpreter what we're going to say before, and actually say very little in sessions, really. And if I do, if it's mercury, I try and join in, and that I think is a really good way of showing the children that you know, sometimes I'll make mistakes and they can laugh at me, and that's okay, and we can have a go at language, and it's tricky, and you know, it's okay to try that. So thinking about that triad, if children have problems with social communication, so autistic spectrum type children, they'll have difficulty acquiring language. If children have a sensory impairment, so they're missing out on the input, so hearing impairment, blue ear, or if they have a deprived input, so if they don't have play opportunities, then they'll have poor language development. And if they have some kind of central language impairment, so they have difficulty with short-term memory, difficulty spotting patterns, then they'll have problems in that part of the triangle. So in Rochdale, we have lots of those things because we have a high instance of blue ear. We have children who live in a very socio-economically deprived area, and increasingly there are more children for several reasons I wish I knew with social communication difficulties. So language is on the agenda for us and for all the teachers and parents in our area. Very traditionally, speech therapists have described children as being language delayed, and they often use this for EAL as well. They say, oh, he's just behind, he's delayed. And I have a major problem with that because children who are slow to talk, the reason doesn't really tell us the reason. And you can only give that diagnosis in retrospect. So you only know when they catch up that they were delayed. What happens if they don't catch up? Were they impaired all along? When children come to clinic, most of the time children are referred between the ages of 3 and 5 because people are starting to look at different settings. Most of the children either say nothing at all, they use jargons, they're using like play talk, or they've got a few single words. I know of no test, and I've done lots of research and searching the literature for this, I know of no test and no questionnaire that can differentiate between language impaired and language delayed children until they've had therapy and input, until they've had language input, until they've gone into a language environment. It's just not possible. So for that reason, we Hedger and Moll recommend that we don't use that term and we avoid it. The other evidence behind that is kids who are called language delayed may appear to catch up with surface conversation, but they still have significant problems with learning and the language of learning and acquiring new vocabulary. And they'll have surface vocabulary, so you'll ask them what the meanings of things are and they don't know the category, they aren't able to describe the items, those kinds of difficulties. So I prefer to use language impairment